I'll just now hand it over to Gary Petersen. Gary, you're on air.
Well, thank you, Priya. Appreciate it. And obviously for all of us, and I'm sure for Tom, this looks like a miracle, and possibly so for not only you and your family and daughter, but for many other people as well. So thank you so much for being part of that clinical trial. And Dr. Grupp, thank you so much for all that you've done as well. I understand that CAR T-cell, Doctor, I understand CAR T-cell therapy focuses on, at least for leukemia, CD19, has some off-target impacts, and that the B cells, as a result, the patient needs a transfusion, and you said it was, I think it's some immunoglobulin. Can anything be done to correct this? Are there any other targets that are just specific to leukemia,
question,
which could eliminate the off-target effect?
Yeah, so first off, if for other kinds of cancer, the target is going to be totally different, and so we wouldn't see this side effect except in B-cell type cancers, and that's leukemia and lymphoma. And so when you get away from this kind of disease, we're not going to see that side effect. There are two ways to get around this, and one way is you can use a short-acting form of the CAR T-cell. So the other CAR T-cell product that was also approved in 2017, a couple months after Kymriah was approved, that is made by a different company. It has a name that's called Yescarta, and that only lasts for a few weeks, and so there's no issue with long-term B-cell aplasia. But the issue for me is that this long-lasting property of the cells that we use is really what's allowing us not to take these patients to bone marrow transplant. That's actually what I do as a doc. I'm a bone marrow transplant doc, and I'm so excited that there are patients like Emily where we can just use this therapy and not transplant, so that long-lasting effect. Now, what can I do about it? Well, you could engineer, we haven't done this, but you could engineer a switch in the T cells so that you could turn them off. And if you remove the reprogrammed or engineered T cells, then the natural B cells would come back and this need would go away. And so the reality is that we probably could erase these T cells from the patients. And after a few years, one of our central questions is that a good idea or not? And I would love, Tom, for you to comment, because this is an area that we talk about at every visit, what you think about the prospect of erasing the T cells.
Yeah, so Dr. Grupp has asked us quite often, and we've always told him that we have a normal child, and what we went through to get them in there, as parents, we would never make the decision to go back in there and erase them. And we said, when Emily gets older and becomes an adult after she's 18, if she would decide that it's time, that it's been long enough, and she would want to make that call, then that would have to be her own decision, because we just won't ever do it as parents. She lives a normal life, and other than that medicine that she gets every other week, we have a normal child.
And how exciting is that, I'm sure.
Yeah, it's pretty amazing. And we saw a lot of parents, that were in at the same time fighting just as hard as we were, and they lost their child, and they would give anything just for one more day with their children. So, we know how fortunate we are. And I've had talks with Dr. June, too, on his research, and he said maybe eventually they're going to have a switch that they can turn the T cells off with a medicine and turn them back on if needed. So they wouldn't have to completely eliminate them. But that's coming in the future with more funding.
Well, that sounds great. One other question, Dr. Grupp. Recent long-term follow-up at Memorial Sloan Kettering Cancer Center. I believe they've been doing some research. They have found that the cytokine release syndrome occurs in 26% of patients, including one patient who died at the rate of severe neurotoxicity, and that was at 42%. So there was a CR in 83% of patients, but the median overall survival was just 12.9 months. So, and the median EFS, event-free, was 6.1 months. So the median follow-up time was 25 months. Is this your experience as well? And if so, is there? This is a far cry from a cure, but what improvements do you see over this, and is yours different in some way?
So yes, it is, and no, that's not our experience. There are patients whose disease does come back after this kind of therapy, and one of the reasons it sometimes comes back is that the leukemia, which is really evil at doing stuff like this, learns to hide that target that you mentioned, which is CD19. And so in that situation, you can have awesome CAR T cells on the hunt, but they don't see the cancer anymore because CD19 is gone. And so that is the problem that we see in some patients. Our long-term experience is considerably better than the numbers that you just mentioned. 50 to 60% of our patients remain in remission 1-2 years out. That seems to be sustained beyond that, but then the number of patients, as we go further and further back in time, we've treated smaller and smaller numbers of patients, including when you want to go to 6 years, there's only one human being on the planet with ALL that's 6 years out, and that's Emily. So 100% of one patient. That doesn't really mean much from a statistical point of view. And so the reality from our standpoint is that the long-lasting characteristic of the cells has allowed us to avoid transplant, and it does keep patients in remission for a long enough period of time that we are hopeful for the potential of cure. But that is 50 to 60% of the patients. It is not 100% of the patients, and so I just want to be clear about that. So we feel like the therapy has legs, and that we're able to keep a reasonable number of the patients. And then you ask the question, how do you improve that? Well, my answer to that would be if some leukemia learns to hide, maybe what we need is a second target. And so we're actively working on clinical trials, and this is actually a major area that we're using the Emily Whitehead Foundation support to go after this. We're actively pursuing a second target, not to treat patients when their disease comes back, although that's how we would use it right now, but in the future to prevent that from ever happening. And we think that having two targets has the potential to bring that long-term disease control rate up from 50 to 60% to closer to 80%, which is a number that still isn't good enough, but is way better than what we have right now.
Well, yeah, exactly. And even a median overall survival of 12.9 months really beats anything that's really out there for late-stage myeloma, for example. And I would imagine that similar for leukemia. I mean, new drugs are approved for 2 and 3 months improvement. So thank you very much, Doctor. And obviously you're doing something right that other people have yet to figure out. So hopefully that will go and become common knowledge at some point in time. Priya, that's it for me.
Thank you, Gary. Jack, please go ahead with your questions.
Good morning, at least here in California. I really appreciate this phone call. I've learned an awful lot. I've been fortunate enough to meet the Whiteheads, a wonderful family, a few years ago in D.C. at one of the Leukemia and Lymphoma Society Foundation meetings. So thank you for all you've done. Dr. Grupp, I have a question with respect to the cytokine release syndrome. Does it vary, or is it better or worse considering the disease that's being treated, or is it strictly related to the amount of cancer in that patient?
Yeah, that's a great question. And so this was a surprise to me. I had a definite prediction, and I was definitely wrong I was thinking that it's all about your disease burden and not the kind of cancer you have, but it's not true. So it turns out that leukemia, like Emily had, is one disease that we treat with this, but lymphoma, which is a different kind of cancer, very related, but it works differently in your body. Lymphoma has a lower rate of this severe cytokine release syndrome. And without, again, I don't want to go over technical to this, but the thing is that leukemia is a disease where there are single cells floating all over your body, in your blood, in your bone marrow, sometimes in the spinal fluid. And when you put in the T cells, they find the cancer right away. And that's where that severe cytokine release syndrome comes from, is that a whole bunch of T cells killing a whole bunch of cancer in a very short period of time. Lymphoma is organized into balls of cancer, almost like a solid tumor. And there, the T cells have to work their way in, and they don't have access to all of the cancer the minute that you infuse the T cells. And that slower ramp up means that patients don't get as sick. So it seems to be very dependent on the kind of disease.
And you've answered most of my other questions. So the one thing we hear about every so often with respect to CAR T is that it may become a procedure where instead of taking T cells from the patient, that T cells or re-engineered CAR T cells can be produced from off the shelf. Do you envision it happening, and can you say a little bit about that?
Absolutely. So the off-the-shelf concept is under active development right now. I myself have treated a patient with an off-the-shelf CAR T-cell product, and we'll be working on another clinical trial where we're going to be trying these cells. And so the hope is that if you didn't have to make this product for every patient, it would be less expensive to basically take cells from a normal donor and make them into a dozen or a couple dozen products, and that would reduce the cost. And so if that turns out to be the case, that would be great, because that would obviously simplify the manufacturing problem. In this case, we have to collect cells from each individual patient. So we have to send it to the facility, the Novartis facility where they make the cells, and then they send it back, or we send them to our local facility as well. And so the issue, though, is that these cells are from another person, and the potential is for your body to say, hey, those cells don't belong there, and your own personal immune system reject those incoming cells. And then you wouldn't have that long-lasting capability. So if they can figure out a recipe where these cells last, where they have legs, where they're the marathon T cells that we were talking about, then this is a real additional step forward that might reduce costs and make the whole process a little bit simpler. If, on the other hand, the cells don't last very long, then it's not going to be as an exciting potential replacement. So right now, we don't have the sense of equivalence, but this is a hot topic. People are working very hard on it. There's a lot of interest in CAR T cells, which means this is a lot of investment in the area from a drug company standpoint. And so these are questions that are going to be answered in the next few years for sure.
Thank you very much, Dr. Grupp, and I'm so excited for your success, your family's success, Tom, and that's it for me.
Thank you.
Thank you, Jack. Thank you, Jack.